partnership is the promotion of excellence in specialist medical training in reproductive healthcare in both the East, Central and Southern Africa region and in the Republic of Ireland. Dr. Lebronon is a consultant of Zingani Mayo University Hospital since 2001. She holds dual specialist registration in obstetrics and gynecology and general practice following training in Ireland and Melbourne. She's led the partnership between Brighter Communities and management teams of Loredani Sub-County and Mayo University's Hospital since inception in 2007 to date. And today Maeve will share with us about the development of the new partnership between the Institute of Obstetricians and Gynecologists, the RCPI, and the East, Central and Southern Africa. So I'd like to welcome you, Maeve, and we'll just hand over to you there. So thank you.
Thank you very much. Thank you for the welcome. And just to clarify, I've actually finished up now in Mayo University Hospital, but our link is being led on by Eddie Conran. And hopefully we have a little team traveling shortly, and we will be paying back our carbon debt. So if I could introduce Judith Andrew, who's also online, who is the program coordinator in the East Central Southern African College of Obstetricians and Gynecologists. Perhaps we can call that EXACOG for the duration of this chat. I don't know if Judith's picture can go up. Probably we're on the ticker down the bottom at this point, but there's Judith on the ticker tape at the bottom. Hello, Judith, and thank you for joining us.
Welcome, Judith.
And I got the straw for doing the verbal presentation, but Judith has contributed the slides and a lot of the content. So thank you for coming back so promptly after lunch. We're delighted to have this opportunity to talk about a new partnership, but we're also delighted to attend this particular partnership meeting over these 7 years, because we go away with little gems every time, whether it's a phrase that data really counts, or grab your allies, make an alliance, you'll have greater leverage, as we see Dr. Firth's group doing for the NCDs. Learn the architecture of partnerships, and that's certainly what we're doing today, and use frontline knowledge, use the knowledge that's there on the ground, use it in the improvement cycle. So all of that leads us now to talk about a new partnership under the umbrella of, will it be a sustainable health partnership? And we certainly hope that it will be. Is that okay? So I'll take the next slide, please. My connection says good, but I'm not seeing the slides going forward. Can you hear me okay?
Yes, we can hear you. I think it's maybe in the venue. I'm checking with them now online.
Thank you.
I think it's the connection maybe in the venue, because we can hear you very well.
Okay, we'll give them a moment.
Yes. Sorry for this.
No problem.
As always. Everyone online, can you hear Maeve well? Yes.
Thank you.
Thank you.
Yes, we can hear.
Perfect, thank you.
And it worked beautifully this morning,
Huh?
the conference room. It worked well in the
Yeah.
room this morning.
I think it's, yeah.
So we're back, Hala, now. Sorry to interrupt you. Sorry, Meg, because we dropped off there for a while.
No worries at
No
all.
problem.
No worries. Thanks.
Okay,
Are we good again? Sorry, Meg, about that. It was the technical.
no problem. No problem. Thank you.
Yeah, thank you.
So I'll take the second slide and go on to the discussion of the context. So why we're setting up a postgraduate training partnership at this point in time. So in the background over the last 20 years, this ESTHER group of partners is very familiar with the great work that's been done with COSEXA, the College of Surgeons, and CONEXA, the College of Anaesthetists in East and Central Southern Africa, facilitated by the RCSI and the College of Anaesthetists in Ireland. And we also have seen the strength of the HSE Global Health Programme, using quality improvement cycles, diversifying its global health education, structuring ESTHER and facilitating Irish aid assistance. And we also see our training bodies grouping together and learning more about global health and trying to make global health more mainstream. So from a top-down approach, if you like, we can see that there's lots of activity has been very forward progressing in the last couple of decades. And in the Institute of Obstetricians and Gynecologists, we've not had a formal response to that until this time. However, many members of the Institute of Obstetricians have travelled with Brighter Communities, and Maria Kidney from Brighter Communities is online with us today, to a community development project in Lundiani, and the Mayo Lundiani Hospital Partnership grew out of that. And the obstetricians who went, many of them came back and to learn more about community development and to understand why maternal survival was such a challenge in this community. And as the community sensitization, education, activation occurred, and as the ministry facilitated the shift towards facility birth, certainly some of the indicators really improved. But at the end of the day, there was still no specialist provision in the district hospitals and in many district hospitals of the area. The surgeon doing the operations is not a trained surgeon. The anaesthetist doing the anesthesia was a clinical officer in anesthesia. And there were no obstetricians in the immediate area where we were visiting. And over the first 10 years of our link there, only one local doctor trained as an obstetrician gynecologist was bonded into ministry service and was posted elsewhere, a good few hundred kilometres away from Lundiani, where there was a priority need. So it made us reflect on how doctors are trained in the area and the loss of doctors internally in some countries to the private sector, to the NGO sector, and to public and population health. Not saying that that's not a good option, but we also want to try and keep some clinicians on the floor. I'm obviously from a clinical background, I apologise. So I'll take the next slide, please. There are other challenges in global obstetrics in that to deliver the Nairobi Summit goals for women's health. I'm still seeing the third slide. Can I have the next slide? Or am I out of sync? Yeah, thank you very much. So to deliver the commitments that our minister signed up for in 2019, and that was alluded to this morning by Anne Holmes from Irish Aid, we need some specialists. Most of this work can be done through societal change and civil society groups, and through midwifery, through nursing, and through other population health measures. But you do need a few specialists scattered around in certain locations. And in global surgery, which is getting some traction, like the NCDs as a current major forgotten burden of disease, about 40% of the surgical provision is obstetric in nature and emergency gynecology. And there are infrastructure, supply, leadership problems. And gynecology really doesn't get a mention at all until we discovered that cervical cancer was preventable through vaccination programs. So a lot of silent burden of disease going on when there's no gynecologist to provide the complex care. So never mind the emergency work, there's a lot of other work that a specialist in obstetrics and gynecology can provide. Next slide, please. Ideally, we would have 40 surgeons, anaesthetists and obstetricians per 100,000, providing about 5,000 procedures for the population. So there are measures there, there's metrics there, and to know what impact we're making. But like many of the health inequality, where there are the largest numbers of needs or births or procedures required, there are often the lowest density of trained staff to provide that. Safety in surgery is proven where there's a certain volume by a certain level of training. It doesn't always have to be a specialist surgeon. It can be a clinical officer who's trained in surgery. It can be a physician assistant. It can be a technical theatre operator. But the supervision and training and auditing should be led and directed through specialist surgeons. So to know what workforce strengthening is necessary both in Ireland and in EXA, we do need to map the workforce. And now in Ireland, as a tiny country with a small population, with a significant number of births, we have a programme that can do that work, and we've struggled to fill our posts. We have funded posts that are lying empty. EXA doesn't as yet know its mapping of OBS and gynae workforce, and that is one of the first projects that this partnership has already started. I'll take the next slide, please. These slides went in before the first talk this morning, but the obstetrician has a role in sexual reproductive health values and rights as well. And in our own 10 years of values and rights discussions in Ireland in reproductive health measures, and the Institute was working away with government committees and with different policy work to ensure that we can move from a country of unsafe abortion to a country of safer abortion, that we can make sure that there's contraceptives available, although that didn't come in the legislation, and it continues to be a challenge for many who don't have the ability to cost share. Next slide, please. So that context and background is a little bit long today, but it's because it's a new partnership. I just wanted to give you the scene for why specialists might be helpful in some of the population health measures that we're addressing. And EXACOG has a very clear vision, mission, and membership to really move along the indicators for reproductive, maternal, and newborn health in their region and beyond, to be influencers, leaders, and to be able to direct policy in their region. And the Institute has been established for over 50 years and comes under the umbrella of the RCPI in Ireland, comes under physicians, even though we're classified as surgeons internationally, and has a very established training program and continues to have huge investment in its training program from our government services. Next slide, please. So we found common ground, and in any match for partnership, we had to make sure we had common ground, that we would, as partners, both gain from collaborating together, looking at innovation that would help the Irish health system, looking at training solutions that may or may not be useful in the EXA region. But just that collaboration, becomes. I just see a note coming through. Oh, thank you. Just that collaboration brings a certain amount of creativity and problem solving that we don't get if we stay in our own systems within our own institutions. So we have identified common ground in trainers and training sites and logbooks and development manuals and continuing lifelong learning. Next slide, please. So we brought, Judith did significant work with her secretariat, and we have a picture here from the Institute, the RCPI, with obstetricians, assisted by a visit from the College of Surgeons in the EXA region, and from our own Institute Global Surgery in the RCSI, who've been incredibly facilitative, supporting, leading, nudging, coaching us through this process. And particularly Eric O'Flynn over the years and Lucia Procato more recently. And our two organizations agreed in March of this year. They met, they introduced each other, they shared vision and agreed to work together, and went away from the table and from the Zoom call and worked on the Memorandum of Understanding, which has gone back to both executive councils and has been accepted for signing. There's been a couple of changes in chairs and presidents and governance that is just taking us a little longer to get through the hoops of a new governance structure within the RCPI, but we're hopeful that it will be over the line fairly soon. Can we have the next slide, please? And meanwhile, while this is going on, we're establishing the principles of partnership and making sure that we have a fit in both institutions. We're using the startup grant that we're very grateful to receive for a face-to-face visit at this time, which is like the gestation of an elephant calf, about 22 months, I think, since Judith and I started talking to each other. So it looks like we'll have the first birth in Zimbabwe by the looks of things, because Judith has proposed that we visit during a regional conference, as it's an easier time to meet face-to-face. And we've decided that our team would actually include a trainee to visit. So from the outset, we have the Junior Obs and Gynae Society, which is very active in Ireland, of obstetric trainees, sent out a call for expression of interest. There was a lot of interest, and the commitment is that this trainee would visit and then agree to work with the working group for the next year to contribute to a trainee-led opinion on the programme from the beginning. And Judith has set up and introduced us to a hospital that we can visit in Western Kenya, as we have the other link work continuing as well, to visit the first training site. And the first trainees are just starting this month, 5 years after EXACOG was founded. And it's very exciting and great success for the program that they are recruiting their trainees at this time. Next slide, please. During our visit, we will check in with the embassy, as we Brighter Communities have forged links there that will allow us to let them know what we're doing in the region. And we also like the community visit when any partners are visiting or any study tours are occurring, just to be able to firsthand hear the patient experience, to have that community voice. So we hope to be able to hear from not just from the specialist side of things, but also from the communities on our visit. And we will attend a scientific meeting as well as the partner meeting. And I think a couple of abstracts have gone into that. Next slide, please. Nearly there. The surgeons and anaesthetists have done great work on mapping their workforce and planning and knowing what the trends and demographics are like, to try and address that urban drift that we all have in healthcare, and to address where the subnational data suggests that there are greater needs than the national data might suggest. So there's wonderful data out there, and the Institute of Global Surgery and the RCSI are wonderful leaders in this field, and very much have moved on at such a great pace. I just hope that I know the EXACOG will be able to keep up, because Judith has already worked with the COSEXA programme. I just hope the Institute in Ireland will be able to keep up as well, because the RCSI has certainly been driving that the development with COSEXA over these years. Next slide, please. So we have a cycle of work, and we're proposing a 3-year cycle, and the identified needs have been the e-portfolio, country engagement, because not all countries are able to engage or have capacity to engage. And if we're to think of the Irish Aid approach of furthest behind first, then those countries that have not yet got master trainers, that have not yet got accredited hospitals, should probably be our first focus, if that's what all partners would agree on. However, the training and methods and exams and logbooks do have to be piloted in the region and made sure that they're fit for purpose. So the countries that have trainees, Kenya, Rwanda and Zambia, will be forging ahead at this time. There is a research group already established across RCSI, COSEXA and the two obstetric partners. And already there is a team doing the baseline data and meeting with the stakeholders, the medical councils and the professional societies in all the country organizations to have permission to access secondary data on their obstetricians, so that the obstetricians can be contacted directly. and that will give some idea for measurement for what will probably be quite a long project, as maybe the gestation of 3 elephant calves, as they have a little bit of secondary infertility after the first calf. They tend not to have their second calf for 4 or 5 years. So I suspect that we might have some similar gestational problems as obstetricians. Next slide, please. So that's all that I have to say, unless Judith would like to come in with anything at this time. But we are really grateful for our enablers and facilitators, David and his team, in pushing us to become more active in this realm, and Eric, Lucia and his team for pushing us from across the Stephen's Green, and then for Judith and her team and for her consistency over this time. And all this started up during COVID because we had nothing else to do.
Thank you very much, Murphy. I hope you have covered all what we had intended to present in this forum, and I'm very excited to join this forum for the first time. I've learned a lot in the morning sessions, especially on the fundraising. So thank you very much to everyone, and we look forward to collaborating with ESTHER and other partners.
Brilliant. Thank you, Judith. That's great. And thank you very much to Maeve. That was a fantastic presentation. That's done, Maeve, yeah. Yeah, brilliant. All your slides are finished, Maeve. Yeah, that's it. Brilliant. So does anyone have any questions from the floor, just in terms of the presentation or just visions of these elephant calves running around it? But it's great to see the progress of the work and the excitement of getting the trainees on board now, you know, at that point. So congratulations to everyone involved. Is there any particular questions that anyone has on the floor just before we move on to David?
Well, if I could just make a comment, and it's
Yeah.
based on the RCSI experience with surgeons.
Can you speak? Can you hear? Maeve, can you hear? Yeah, brilliant.
Yeah, I think the collaboration, the work of COSEXA, the College of Surgery Centre of Southern Africa, has transformed the landscape of surgical training in Africa.
Mm-hmm.
And the huge change from people leaving Africa to do their surgical training to now being trained on the continent.
Yeah.
That's transformational. Mm-hmm. And the collaboration with RCSI has been very instrumental in some of the changes that have taken place. And I see a similar potential with this collaboration.
Mm-hmm.
This is going to address similar issues within the area of obstetric care. And it ties in very much too with the RHA priority, sexual reproductive health. Mm-hmm. And so I think this is a very exciting development. I think it's very timely, and I think it's huge opportunity and potential. And I wish you well, Maeve and Judith.
Yeah.
I hope the gestation doesn't take quite as long.
Yeah, well done. Anyone else? And is it from your experience or from the college?
As a program, so thank you so much to Irish Aid, also that supported the collaboration program for more than 15 years.
Excuse me, we can't hear you very well. Sorry.
I say thanks to Irish Aid support that supported the COSEXA and RCSI for about 15 years. And we are pleased to facilitate the collaboration of the two colleges. I'm very pleased to see Judith participating today, and you could also share the European network. This is very important as we exchange information and experience. And I'm here to still facilitate this partnership and cooperation. So anything you need, please give us a shout.
Brilliant, that's great. Thank you very much. Thank you very much, Maeve, and to Judith. It was a fantastic presentation. Okay, so our next presenter again going to be online is from Dr. Freddie Katutu, who's a senior lecturer. You can hear. Maybe we could just put on mute. There, sorry. Yeah. So it's Dr. Freddie Katutu. He's a senior lecturer of health systems, pharmacy and research at Macquarie University. And he's from the antimicrobial stewardship program by the partnership that involves Macquarie University Health Services in Uganda and Buckinghamshire Healthcare NHS Trust in the UK. In Uganda, he teaches courses of infectious diseases, pharmacy, research methods, and pharmaceutical policy to undergraduate and postgraduate pharmacy and public health students. He has previously served as the Dean of the School of Health Sciences at Macquarie University and is part of a multidisciplinary group of researchers and scientists who conduct inquiry at global level into how to create and co-formulate sustainable pharmaceutical systems in low and middle income countries. Since the inception of the Commonwealth Partnership for Antimicrobial Stewardship by the Commonwealth Pharmacists Association and the Health Education Trust, he's been a volunteer clinical pharmacist in 4 health partnerships in Uganda and remains active in 2 of them. So that's some CV, Freddie. So looking forward to hearing your presentation. I'd like to welcome you here and I'm over to you. So thank you.
Thank you very much. I hope you hear me.
Very good, yeah.
Excellent. Thank you very much for the kind introductions, and we'll move straight to my presentation, which will basically highlight the work between the Health Education Trust, which are referred to as ESTHER, and the Commonwealth Pharmacy Association, who came together to implement the Commonwealth Partnership for Antimicrobial Stewardship in several countries in Africa. I'll focus on 2 health partnerships in Uganda. Next slide, please. So for those of us who may not know, Uganda is located in East Africa. Next slide. And it is a landlocked country surrounded by Kenya on the east, Tanzania on the south, and South Sudan on the north, and the big DRC on the west. Next slide, please. In terms of context, our population has one of the highest growth rates, currently estimated at 42 million, a total fertility rate of about 5 children per woman, as indicated by the previous speaker. Maternal mortality ratio is still high, and that's why we need a lot of the partnerships are focusing on reducing deaths among women and children. Child mortality rate is also still high at 43 per 1,000 live births. And then for antimicrobial stewardship, I think it's important to understand how health is funded if we are going to focus our efforts where we think work should be done. And for Uganda, our government funds about 15% of the health expenditure, and that largely goes to human resources and infrastructure. We receive a lot of support from health development partners at about 41%, and these include Irish aid and UK aid as well. And then there is out-of-pocket expenditure of about 40% again. This is money from household income that is directed towards life-saving health services. Insurance is very minimal at about 5%, and that access is still very low. Next slide, please. So as everybody knows, antimicrobial resistance is one of the biggest threats threatening humanity among the top 10, and following guidance at global level. And so countries were advised to set up antimicrobial resistance national action plans, which are basically policy level documents that highlight and emphasize priorities that countries need to implement, usually in a One Health fashion, so focusing on human health, animal health, and environment, so that they can reduce the drivers of antimicrobial resistance. I'll focus on antimicrobial use, which is one of the proven drivers of antimicrobial resistance, given that increased use of antimicrobials typically drives antimicrobial resistance. And here, what we see on the slide is the Antimicrobial Resistance National Action Plan, and then the picture of the Honorable Minister on the day when it was launched in 2018. So until now, we're guided by this document, and a lot of the activities I'll focus on were supported at policy level by priorities in this document. Next slide, please. As far as governance is concerned, again, from that document, we have the One Health platform that focuses on basically all health conditions that are related to both human, animal, and environment. And those include zoonoses, diseases that can spread from animals to humans. They include pandemics like Ebola, and COVID-19 fits in those as well. Below the One Health platform is the National Antimicrobial Resistance Subcommittee, which is again guided by the 5 core objectives that reflect what is in the WHO Global Action Plan on Antimicrobial Resistance. And we see that there's a priority to ensure that there's public awareness, training, and education. There's a priority on improving infection prevention and control. There's a priority on antimicrobial stewardship, optimal access and use, where a lot of our work is embedded. There's a priority on surveillance of resistant bugs, and then a priority for research and infection. As part of this, to ensure that information is generated and shared at regional and national level, the country has appointed focal persons who ensure that antimicrobial resistance data is shared with the WHO Global AMR Surveillance System, and then also antimicrobial consumption data, and I'm the focal person for that currently in the country. Next slide, please. Again, emanating from the National Action Plan, guidelines have been developed to focus on surveillance of antimicrobials, particularly antibiotics in animal health and human health, and a lot of activities that were implemented with support from FET and CW PAMs were basically guided by the national guidelines for antimicrobial consumption. But again, the other point I need to state is that the development of these documents was partly also an offshoot of the emphasis by the FET and CW PAMs to build a capacity within the country for us to be able to implement some of the priorities in the AMR National Action Plan. Next slide, please. Yes, as one of the outputs of the CW PAM's work, particularly with me as a focal person, was to ensure that in the new National Pharmaceutical Sector Strategic Plan, which usually runs for 5 years from 2020 to 2025, there was clear emphasis on actions and activities that are aimed at strengthening antimicrobial stewardship at all levels, including national level, focusing on Ministry of Health and Ministry of Agriculture, but also at a subnational level within districts and at health facilities and the community as well. Again, this very much borrowed from the emphasis and support from FET and CW PAMs, but then also provide guidance for ongoing work as still supported by the collaboration between the UK institutions and Ugandan institutions. On the left of the slide is again an important document, the Medicine Therapeutics Committee, which again formed the platform within which the CW PAMs and institutions in Uganda were able to implement activities on antimicrobial stewardship in a way that was coordinated and in a way that was building on what the Ministry of Health had already prioritized. Next slide, please. This is basically an extract from the strategic plan, which focuses on the strategy on strengthening antimicrobial stewardship at all levels. And you see that a lot of what CW PAMs emphasized was well captured in this document, and it remains an aspiration of the country, and again within our health partnerships between the UK and Ugandan institutions, which I'll be talking about briefly in more detail, trying to emphasize, particularly at the health facilities. So focusing on, for instance, objective number 7, action number 7, which looks at developing, disseminating, and implementing relevant provisions of antimicrobial stewardship national action plan, including operational guidelines and policies. And then also number 8, developing and disseminating the reporting platform for monitoring implementation of antimicrobial stewardship interventions at health facilities, where we basically need to do surveillance and be able to use the information being collected from the facilities to guide the next priority actions. Next slide, please. Next slide, please. Yes, so the CW PAMs, as I mentioned, is a partnership, and one of the things is to build on expertise in the UK hospitals, partnering with institutions, hospitals in Uganda, Uganda being one of the low-income countries that is part of this global program. So as far as Uganda is concerned, in the first round, which started in 2019, 5 hospitals in Uganda partnered with 5 NHS hospitals in the UK to build capacity of antimicrobial stewardship, and has already provided the policy platform that provided provided areas of input where the medicines therapeutic committee manual. So what we did is identified hospitals where there were no medicine therapeutic committees, which are referred to as MTCs, and we supported them building on and borrowing from expertise from the UK pharmacists and pharmacy teams in the institutions that were participating. Next slide, please. Yeah, and next, so what we did is ensure that the MTC has a role in AMS and IPC. We basically worked with the hospitals to support the nomination and identification of people who would make up such a committee, which had to be multidisciplinary, including pharmacy, medical doctors, nurses, an administrator, a biostatistician. And this committee basically sits together to prioritize and pick out, for instance, data that needs to be collected to inform their decisions in terms of promoting appropriate medicine use, or even identifying whether they are having enough medicines to treat the common infections that the patients present with, or whether the lab has an adequate supplies to be able to support the clinical decision making. And then also focus on infection prevention and control, which are referred to as IPC. As we know, it's probably the most effective way to reduce the development of resistance and spread of those resistant organisms, either from patient to patient, from health worker to patient, and vice versa. So the MTC was supported to start and implement activities that directly influenced the antimicrobial stewardship capacity at the hospital, and then infection prevention and control. Next slide, please. So let's have next. Yes, and the whole point, thank you very much. The whole point basically provides a framework within which we worked. Basically, together with partners from the UK, we did a needs assessment that focused on health workers' knowledge, skills, and capacity, and then also the health facility capacity. We also used globally known tools known as the Point Prevalence Survey, which basically looks at how antibiotics are being used, whether it's appropriate or not, whether it's according to the treatment guidelines or not. And using that information, we prioritized what the MTC needed focus on. And again, the interventions, again, here referred to as the customs intervention, focused on, for instance, creating awareness among the people, setting up processes, for instance, standard treatment guidelines for certain conditions that were not being managed properly, but also for best practices such as hand washing at particular moments, commonly referred to as the 5 moments of hand hygiene, and then the structure. So setting up the MTC, helping them to be able to prioritize activities and communicate those activities so that they are able to be implemented at the ward level, and then also to ensure that they are seeking the necessary support from management in terms of individuals being appointed, but also in extra resources that were required. And some of this was done through workshops and support supervision, including visits where we partnered with volunteers, NHS volunteers, pharmacists, and behavioral scientists together with us in Uganda, visiting the hospital to support this. Next slide, please. So this is a summary of what we did. Next slide, please. And I'll go through quickly some of the outputs. So with support through the CW PAMs, we're able to do a national level consumption audit, where we looked at central medical warehouses and identified which antimicrobials were basically available in the country and where they were being distributed, again, as a way of understanding what antimicrobials are being used and how that influences the development and spread of antimicrobials. This work was published in a paper, and if you can see the cursor, that's what I'm referring to. But we're also able to do through the same health partnership support to do point prevalence surveys using a protocol that is typically used in the global north developed by Antwerp. And we did this in Uganda, but also in countries that were participating, including Ghana, Zambia, and Tanzania. And we're able to basically provide one of the earliest evidence about antimicrobials and stewardship interventions and how the CW PAMs had changed the landscape in these hospitals. Similarly, we did another point prevalence survey in 13 hospitals 1 year later and also reported. And generally, one of the findings out of this was that a lot of antimicrobials were being used for prophylaxis for surgical procedures, which is typically well understood. However, the challenge was that the prophylaxis was going on for longer than is recommended. So typically, 1 day to ensure that any microbes that could have infected a surgical wound are cleared. But in these hospitals, we saw a prophylaxis going on for 3 days, 5 days, which from our assessment was not indicated. And of course, the results were shared with the hospitals, and discussions of it to intervene were also considered. Next slide, please. So these are some of the pictures, and here we see health workers from Jinja Hospital who were beneficiaries of the training that we co-developed with health workers from the University College London Hospitals and London School of Hygiene and Tropical Medicine, who were the UK partners in this health partnership. And after the training, they were invited to join the antimicrobial guardian movement, where they pledged certain actions that will demonstrate that they would give them opportunity to illustrate the knowledge and skills acquired from the training, and then also the ongoing movement of trying to be stewards of antimicrobial, the current effective antimicrobials, so that they can last longer. The picture on the right of the slide is basically one of the training sessions using PowerPoints and facilitator, but of course very much interactive to capture the adult learning principles. Next slide, please. Again, additional outputs. On the left, we have a session where we're joined by one of the members, the commissioner of pharmacy from the Ministry of Health. And the importance of this is that these activities were not only focused at the health facility, but they were much linked with the national level policymakers and decision makers. And here, the commissioner was addressing the health workers about the priorities of the department, but also the importance of addressing antimicrobial resistance from the point of antimicrobial stewardship. On the right, we have, again, the enthusiastic healthcare workers after their training displaying their certificates of attendance and so on and so forth. Next slide, please. And this again at Jinja Hospital, where we're joined by our partners, volunteer NHS health workers. In the center is Preet Penasa, who is a lead microbiology pharmacist at the University College London Hospitals. And then we're also joined by the behavioral scientist, Dr. Corina Ware, who at the time was based at the Manchester Change Exchange group that focused on behavior change for microbial stewardship. And we see Professor Claire from the London School as well, as somewhere in the middle where the cursor is. And on the right is again another session where we had partners joining us, and this was national level stakeholder meeting of the national level antimicrobial stewardship task force, where again findings and learnings from the health partnerships at the hospitals were shared, and those with policy implications were discussed and directions were given. Particularly here, the discussion was about laboratory support for clinical decision making. And one of the leading medical microbiologists was making her point right at the back on the importance of strengthening this. and why it can only it is only after labs are functioning well that we shall be able to do proper microbial stewardship. Next slide, please. Again, this is a session where we're preparing to go and do point prevalence survey. On the right, this is again the partnership supporting the Secretariat of the MTC with basically equipment, a laptop, and a printer, so that they're able to run the MTC activities, communicate, print standard treatment guidelines, and then also share any results from the audits, the infection prevention and control audits and consumption audits with the physicians and all the healthcare workers who need to take action. Next slide, please. Yes, and then we move to the second partnership, which saw a team from the Buckinghamshire NHS Trust in Buckinghamshire with the Makerere University Health Services. And what we see on the left of the slide is the team that basically put the health partnership together and worked using the health partnership principles of FET to build capacity for microbial stewardship at the Makerere University Health Services. And again, a story of this partnership has been published on the FET website, and this link hopefully can be shared for those who want to learn more. But basically the same model using expertise from the UK, working with multidisciplinary team members in Uganda. We set up an MTC at the hospital and then build capacity of the health workers for microbial stewardship interventions, and then also IPC. And probably one of the standout was using an antimicrobial stewardship game that was developed by the CW PAMS to basically find a creative and interesting way of passing on some of the knowledge and skills of antimicrobial stewardship. And we applied this game, and health workers found it very, very helpful and enjoyable, but also informative and educative on some of the important concepts of antimicrobial stewardship in health facilities. Next slide, please.
And you might keep going through the next couple of slides quickly because we're just a little short of time. So if we've got the next couple.
I thank you. I think I have two more. Next slide. Yeah, so this is again a slide showing us when the Ugandan pharmacists visited the BHT for bi-directional learning. And what we have here is basically the biweekly quality improvement hurdle. Next slide, please. Yeah, these again pictures showing us the interactions between the Ugandan pharmacists and BHT pharmacists. Next slide. The same thing, this is visiting the microbiology lab at BHT and going through how audits are done at BHT. Next slide, please. So the summary of it is that through this arrangement, we've been able to increase awareness among healthcare workers about AMR as an existential threat, but also the NHS volunteers have benefited immensely in terms of their leadership skills, project management, being able to work across cultures and contexts, and their understanding of challenges of low and middle income health systems. And then health facilities in Uganda have set up MTCs that can continue implementing this in a way that is sustainable. And then there's also better understanding of the status of antimicrobial stewardship and IPC. And generally, the partnership is a good model for bi-directional learning and knowledge exchange. And with that, I thank next slide, all the partners who have supported, who appear on this next slide, which basically is the UK government and the Fleming Fund and the NHS institutions, but also the Ministry of Health in Uganda, Makerere University, and the hospitals that have been very supportive. And in a way, a bridge has been built between NHS through the FET and CW PAMS partnerships. Thank you very much.
Thank you very much, Freddie. That was great. Thank you very much, Freddie. Unfortunately, in the interest of time, we don't have actually any time for any questions. So I'm going to just hand straight over to Maisie now for the next section. So thank you very much for a very informative presentation. Okay.
Hi everyone, so we've got about 30 minutes now and we're going to have a networking session. So the way it's going to work is Hala will be with the online participants and she'll kind of break them up into groups and we'll break up into groups here. Aveen will go around and give everyone a colour and just match up with people in your colour. I think probably about 5 groups or so, Aveen. You'll have about 15 minutes. We'll put a slide up with some prompts if you want to use those just for kind of ideas of what to kind of chat about, ideas of prompts and questions. And then after about 15 minutes, we'll switch around and we'll do a second group just so that everybody gets a bit of time to kind of chat and talk to each other about each other's roles and partnerships. Is that okay? Thanks, everyone. Yes. Yeah, perfect. So I have some prompts up on the slide here. So just some ideas if you want to use them in terms of introducing yourselves, in terms of talking about your different interests in your own and other health partnerships, and general overview of your health partnerships that you're involved in. It's just some ideas there to get you all talking. Is that okay? Thank you.
Okay, and for the online, I think we can take it from here. So I will put you now into breakout rooms, and then I will put some reminders of the time, and you will have like about 15 times, and then I will go to your breakout room and paste those ideas. But of course, like you're free to talk about and discuss anything. So I will now randomly allocate the breakout rooms, but then if I find few who are not online, then I would change a bit. So it might take a bit of time, but please be patient with me. Okay. Thank you. Okay, so let's do this.